the family that endowed this lectureship has been doing so for almost a decade now. We've been able to bring in excellent speakers as a result of this endowment. The endowment was set up in memory of Dr. Gilbert and Mrs. Hyatt's parents, who basically had a lot of interest in education and furthering education. And so we are really lucky that we have this endowment, and we are even luckier that today we have Dr. Atul Malhotra, who's going to be giving us a talk on OSA in 2026. I've known Atul for a really long time. He's incredible in his productivity. He's currently the Vice Chair for Medicine for Research and a Peter C. Farrell Presidential Chair and tenured Professor of Respiratory Medicine at UCSD. And he was previously the past president of the American Thoracic Society, our premier society in respiratory medicine in 2015 to 2016. I didn't realize it was that long ago. He graduated, he's a Canadian, and which is a good thing, right? Majored in chemistry in University of Alberta, went to med school there, and then came over to the States. He was a resident at the Mayo Clinic, and then moved to Harvard and did the combined Mass General and Brigham's Pulmonary and Critical Care Fellowship. And then under David White's in David White's lab was a research fellow there, where he began doing his research explorations. However, Atul is one of those people who's incredibly smart clinically and in research productivity, and so he does research across pulmonary critical care and sleep medicine, primarily focused being on obstructive sleep apnea. As a result of his investigative work, OSA is no longer considered a single entity, but is understood to be as a result of multiple physiological mechanisms. And so it's allowed for individualization of therapies, and his work has primarily paved for successful pharmacological therapies for OSA, and all of the current therapies, especially GLPs, in OSA is as a result of his work, and he's going to be presenting some of that data today. He's ranked between number 1 and 3 globally on expert escape, and he's ranked in the top 20s for ARDS. So he doesn't do just OSA work, but work on mechanical ventilation and ARDS. Especially the molecular biology of it. He's moved towards AI work now in large databases, and he's recently co-founded a startup, Sisio, I guess, and it's about predictive analytics in sepsis. So, like I said, he's incredibly multi-talented. So great pleasure to introduce Dr. Malhotra as our Seidemann lecturer for this year.
Great, thank you very much. Reminds me of that joke. What's the definition of a genius? Somebody with average intelligence who has an Indian mother. So there are some disclosures here at the bottom that are relevant. In particular, Eli Lilly paid for the Surmount OSA study that I'll talk about. Obstructive sleep apnea affects about 1 billion people worldwide. We published this in the Lancet Respiratory Medicine about 5 years ago, estimating what sleep apnea prevalence was. There are a lot of countries where there are no estimates available, so we did our best guess based on population statistics and body mass index and gender and race and other available data through public records. Came up with a number of about 900 million or close to 1 billion. That's with a fairly generous definition of sleep apnea, with an apnea-hypopnea index over 5 events per hour, breathing problem once every 12 minutes, which some people say is too liberal of a definition. But if you use a stricter definition of more than 15 events per hour, there's really no debate that treatment is required, Still talking about 500 million people worldwide. That number is increasing, not decreasing over time. So if you use a strict definition of 15 events per hour, we're talking about 424 million patients worldwide with sleep apnea. Now, some people say, who cares? Why does it matter if there are people out there with sleep apnea? Unless they come to clinical fruition, just leave them alone. And so we did this paper a few years before that in Lancet Respiratory Medicine. Raphael Heinzer trained in my lab in Boston, and he went out into the community in Switzerland and did polysomnography, full sleep studies on people in Switzerland. I'll point out there's a lot less obesity in Switzerland than there is in the United States, but in that context, using a strict definition, more than 15 events per hour, saw about 23% of women and about 50% of men met the definition of sleep apnea based on strict definitions. And again, people said, who cares? Unless they come to clinical fruition, leave them alone. Well, in that context, we did a multivariate analysis, and the apnea-hypopnea index, the number of cessations plus reductions in breathing per hour of sleep, were predictive of hypertension, diabetes mellitus, and depression. So it's hard to say, let's just ignore these people when we know they're afflicted with important conditions. I'm not saying sleep apnea is necessarily causing all these things, but some of these patients are suffering, and just saying ignore them unless they come to the doctor really doesn't make any sense. But it does lead to a concept that sleep apnea is highly prevalent, but not all these patients will get cardiovascular benefit from CPAP, continuous positive airway pressure. Why would I say that? It would surprise me if 50% of men in Switzerland had cardiovascular benefit from CPAP, because not all are at cardiovascular risk from sleep apnea. Some will die of cancer, some will die of Alzheimer's, and some will die of heart disease for other reasons. It's this sort of one-size-fits-all approach of just giving everybody CPAP and hoping it helps is doomed to failure. We published this in the Lancet Respiratory a few months ago, projecting the global burden of disease in the future. And the reason to do that is some people say this problem is going to go away with GLP-1s. We'll all be skinny in 5 years, and I can certainly say I hope so, but I don't think so. So when we did our prevalence estimates in the future, the numbers are increasing, not decreasing over time. Sleep apnea prevalence is increasing, particularly in women. GLP-1 receptor agonists have some effect, but not a major effect at a population level. Sleep apnea will increase to about 77 million cases by 2050. Females increase about 65%, and males about 19%, based on current trends in terms of population growth, body mass index changes, aging of the population, et cetera. So take-home message so far, sleep apnea affects up to 1 billion people worldwide. That number is increasing, not decreasing over time. The numbers vary with the scoring criteria and the equipment used, but we need to think about how to address this global burden of disease. So why am I showing you this? Well, I'm a big Lakers fan, as David Cohen knows, and at the time he was playing for the Celtics. This is Shaquille O'Neal. He's my most famous patient. And the reason I'm showing you this is for 3 reasons. Number one, it's cool. Number two, when I met him, I said, I got to tell you I'm a hardcore Lakers fan. He said, yeah, me too. I said, because of Magic and Kareem? He said, yeah, me too. But there's a stereotype of sleep apnea. It's older, obese men who drink and smoke. But that's a stereotype. So I have a clinic full of skinny women, postmenopausal women, elite athletes like that. He looks pretty heavy on TV, but up close he is cut with rippling muscles and whatnot. The day that picture was taken, he had moderate sleep apnea. And so you don't have to be an older, obese man. The stereotype of sleep apnea is simply a stereotype. But the real reason I'm showing you this is my wife says he makes me look thin. So he's now doing ads for tirzepatide on television talking about moderate to severe sleep apnea, and that was based on the sleep recording we did that night in his home. So there's a study that's well known to many that was in the New England Journal of Medicine about 10 years ago now called the SAVE study. Look at CPAP, continuous positive airway pressure for the prevention of heart disease in people with sleep apnea. The bottom line is that it was a negative study. Therapy with CPAP plus usual care, as compared with usual care alone, did not prevent cardiovascular events in patients with moderate to severe sleep apnea and established heart disease. The question is why? So for me, there are at least 3 or 4 take-home messages from this study. Number one, we need better therapies and better adherence. This was a well-done study. The authors were aiming for at least 3 hours per night of CPAP use, and they achieved that. But maybe that's not good enough. We need to identify high-risk patients better. As I said, giving 50% of men in Switzerland CPAP and hoping it helps heart disease is doomed to failure. We need more basic research regarding mechanisms, which is a shameless plug for my lab. And maybe we need to treat the underlying cause, which in many cases is obesity, which we largely ignored until recently. So different therapeutic approaches to sleep apnea. You can use CPAP to hold the airway open. Some of these lectures come into CPAP bashing sessions, so I'll tell you a little bit about CPAP that's a bit more positive because it's not, reasonable to have a defeatist attitude about it because it does help many patients. You can treat the underlying cause based on mechanism. I'll be relatively superficial there. If you invite me back for pulmonary grand rounds, I'll give a more detailed lecture there. Treatments to facilitate PAP therapy, positive airway pressure, you can do that with various things. Treatments to improve symptoms are out there. Treatments to block complications of sleep apnea are also there. We have some work in the microbiome and whatnot, which we may not get into today. But let's talk about CPAP to hold the airway open. Some people have a defeatist attitude about CPAP, the mask, and say nobody can tolerate that. There are over 25 billion nights of data on the cloud now. The machines that have CPAP send data up to the cloud, and we can now mine that data, those data. There's a group called MedX Cloud, which is an academic industry partnership. It's funded by ResMed. I don't take money from ResMed or from MedX Cloud, but they did give a donation to my university by way of disclosure. So from 25 billion nights of data, it's kind of fun. We can do all kinds of analyses. I'm a physiologist, so I usually study 10 or 15 people. Studying 25 billion is like a kid in a candy store sort of situation. This was drawn from almost 1 million patients. There's 60,000 patients in the blue line and 60,000 propensity match patients with the red line. On the x-axis here is time. On the y-axis here is the cumulative percent of patients. And this is CPAP adherence based on US Medicare criteria. The blue line is usual care. About 70% of patients meet US Medicare criteria for CPAP adherence, and the majority of people tolerate it. That compares favorably with inhaler use in asthma, anticonvulsant use in epilepsy, or glycemic control in type 2 diabetes. If you look at active patient engagement, the red line here, that's technology built into the machines where patients get a thumbs up if they're doing well, helpful hints if they're doing poorly, active patient engagement. We're looking at about 87% of adherence based on US Medicare criteria, which is really quite good. And this idea that nobody tolerates CPAP is simply wrong. Now you might say not everybody's on this slide, and that's true. We tried to be as inclusive as possible. So if you could get a machine and plug it in and use it for 1 hour in total, we included you on this slide. If you had no access to healthcare, or you had no electricity, or you couldn't afford a machine, or you absolutely refused a machine and never got a machine and plugged it in, you'd never get onto this slide. But if you could get a machine and plug it in and use it for 1 hour in total, then we included you. And between 70 and 87% of patients are using CPAP regularly. And so this defeatist attitude saying nobody uses it is simply incorrect. If that sample size wasn't enough, we looked at 2.6 million patients. We're seeing about 75% adherence based on US Medicare criteria. We did some global health analyses as well. Luciana Drager is a colleague in Brazil. We looked at 4.1 million patients in the United States, 31,000 in Brazil, and 16,000 in Mexico. And we're seeing adherence that's reasonably good across the board, 74% in the United States, 72% in Brazil, and 66% in Mexico. Now you might say these are different patients. More affluent patients maybe come to clinical fruition in Mexico, less so in the United States, and that's true. Part of the point here was to compare adherence across different healthcare systems and say that acceptable levels of adherence can be achieved across the board, recognizing differences in different countries. These patient engagement tools, the thumbs up if you're doing well, active patient engagement, were associated with a 2x benefit and were grossly underutilized. So they're built into the machines, people just need to turn it on and use it, and they were grossly underutilized, particularly in under-resourced areas. So there's an actionable item there where we can improve adherence just by turning on the existing technology. About 80% of patients were meeting Medicare criteria at 1 year, suggesting the potential for sustained benefits. So we published this meta-analysis in the Lancet Respiratory about a year ago now, and this was a little bit controversial, so I'll go through it. On the left, lost the mouse. There. On the left is cardiovascular mortality, on the right is all-cause mortality. The top trials are randomized controlled trials, and the lower ones are non-randomized studies. If you look just at randomized controlled trials, which are the ones that matter, we don't see statistical significance for CPAP in terms of cardiovascular mortality or for all-cause mortality, although trending in the right direction. If you include the non-randomized studies, you do see statistically significant improvement in cardiovascular mortality and in all-cause mortality using CPAP for treating sleep apnea. Now, these non-randomized studies are problematic because there's residual confounding. You can't account for things you don't know unless you balance them with randomization. And there's what's called the healthy user effects. The people using their CPAP are healthier than people not using it, maybe have better health literacy, better socioeconomic status, et cetera. So non-randomized studies are not as good as randomized trials. However, the sample size in the randomized studies is about 5,000 in total, and the non-randomized is about 1.1 million patients. So statistical power we have in non-randomized studies is much better. The randomized trials tend to be of short duration, relatively asymptomatic patients, relatively few cardiovascular events, and so they are quite underpowered. So these data are consistent with the idea that CPAP has benefits for both cardiovascular mortality on the left and all-cause mortality on the right, but not definitive proof until we have large randomized studies showing us the benefits. So I'll conclude that portion of the talk saying CPAP improves symptoms, improves blood pressure. I didn't show you that, but it's true. Transformative benefits for some patients, and a defeatist attitude about CPAP is really not justifiable. But there's general agreement we need new therapies based on ongoing research, which will be the remainder of my talk. You could do upper airway surgery to help patients with sleep apnea. So you've seen the ads on TV for the Inspire device, the remote control thing. It's a surgery that's done, it's a pacemaker type thing for the tongue that can work quite well. We just published last week a new technology on that, so I'll show you the results now. The new study was based on this study, which we published in JAMA ENT 2 years ago now, called targeted hypoglossal nerve stimulation. We now call it proximal hypoglossal nerve stimulation. So the hypoglossal nerve is the 12th cranial nerve that feeds the upper airway muscles and pushes the tongue forward to prevent collapse at the back of the throat. Using this technology, we saw improvements in the apnea-hypopnea index and in the oxygen desaturation index. The Inspire device you see on TV was based on a New England Journal paper back in 2014, which was not a randomized study. It was a case series. I wrote the editorial on that New England back in 2014, and I thought at the time it was important to get a new. Thought at the time it was important to get a new treatment out there, and so I accepted that paper for publication. But surprisingly, a randomized study hadn't been done until this one. That led us to a more definitive randomized trial we call the Osprey study. I presented this at the American Thoracic Society last year, and the Annals of Internal Medicine just published our pivotal randomized trial. So proximal hypoglossal nerve stimulation. The press releases are here. The design of the study is above. We had a primary endpoint in a randomized controlled trial, so everybody got implanted. 2/3 had it turned on right away. 1/3 had a delayed start. So we looked at the response rates based on the so-called share criteria, and we're seeing a much better response rate with treatment versus controls. Prior to that, we didn't have a control group, and so it's hard to know what the actual response rates were. This is our primary endpoint, and we met that with statistical and clinical significance. Looking at longer-term outcomes, we're seeing up to 65% response rates. The median apnea-hypopnea index coming down to 11 events per hour, the desaturation index down to 11, which is really kind of an acceptable result. So this was just published last week, or 2 weeks ago, in the Annals of Internal Medicine, proximal hypoglossal nerve stimulation for obstructive sleep apnea, the Osprey study. And based on this, we got FDA approval in March of 2026. And so it's a new treatment for sleep apnea that may be simpler and easier than the existing technology, and it's been subjected to randomized controlled trials. We have a host of different patient-reported outcomes. We had better diversity than prior studies. The Inspire device done on TV was done in a cohort that was 97% white and really not very generalizable. Okay, so let's talk about treating underlying cause based on mechanism. As Jag said in the introduction, we know sleep apnea is a heterogeneous disease. It has different endotypes, meaning mechanisms of disease, and different phenotypes, meaning clinical expression of disease. So Janet Raffleson in my lab has been working on this. There are anatomical factors that are important in terms of mechanism. There's pharyngeal dilator muscles that are targeted by hypoglossal nerve stimulation, etc. So-called arousal threshold, propensity to wake up. There's a concept called loop gain, which is important in mechanical ventilation as well as in sleep. It's a control of breathing term, which we can get into. Bottom line is patients don't all get sleep apnea for the same reason. This one-size-fits-all approach of giving everybody the same treatment has largely failed. There's a woman named Li Xuan Yi, who's a PhD nurse who worked with us in Boston. Prior to that, she was in Philadelphia, and she looked at the Iceland cohort and did a cluster analysis looking at the different phases of obstructive sleep apnea. These patients look quite different clinically sometimes. There was a third that had disturbed sleep or insomnia, so-called COMISA, the patients with sleep apnea and comorbid insomnia. About a third of patients fell in that category. There's a group that was minimally symptomatic or asymptomatic, that was about 25% of patients. A group with severe sleepiness, that was about 43% of patients. The reason this matters is that Diego Mazzotti had a paper looking at that 43%, that was the group that was at cardiovascular risk. These other patients were not. The reason that matters is if you take a one-size-fits-all approach and just give everyone CPAP and hoping it prevents heart disease, it's doomed to failure because fewer than half are at risk of sleep apnea-related cardiovascular complications. And so, again, this one-size-fits-all approach doesn't work, and this differential susceptibility is an important concept. So we've used these principles to try and guide therapy. They're upper airway muscle dysfunction that's seen in some sleep apnea patients. We have this device now called Excite OSA or signifier. You put this in your mouth for 20 minutes a day. It electrically stimulates the muscles and improves the endurance of the tongue, which we previously showed to be deficient in patients with sleep apnea compared to controls. By way of disclosure, a good friend of the CEOs, I don't take money from this company, but we have a friendship. If you do that with this electrical stimulation 20 minutes a day, you see improvements in the apnea-hypopnea index, improvements in snoring, improvements in other things. So we're looking to do now randomized trials using this technology to actually improve harder outcomes, but it is FDA approved now. There are other approaches to activating the hypoglossal muscles and the upper airway muscles, including pharmacological ones. So my former lab at the Brigham spun out a company. I have no affiliation with the company. It's called Apnimed. But they have a drug combination of atomoxetine and oxybutynin. Atomoxetine is Strattera, it's an adrenergic drug. Oxybutynin is Ditropan, it's an anticholinergic, and there's an enantiomer that they developed for patent reasons. And so they did this phase 2 randomized study, which is called Mariposa, published in the American Journal of Respiratory Critical Care Medicine. They did see some improvements in the apnea-hypopnea index using that. If you look carefully at the placebo-adjusted results based on modified intention to treat analyses, the improvement was about 5.9 events per hour in terms of the apnea-hypopnea index, which is pretty good, but not amazing. They did 2 phase 3 randomized studies, which are not yet published, but they were presented at the American College of Chest Physicians. This drug combination of atomoxetine, oxybutynin, and a drug combination to treat sleep apnea had fairly consistent, though modest, effects on obstructive sleep apnea. The apnea-hypopnea index improvements they're seeing are between 3.3 and 4.5 events per hour in their modified intention to treat analyses. The press releases look much more rosy than that, but if you look carefully at what they presented, at least, it's more modest. About a third to half of patients dropped out of those 2 phase 3 studies. Side effects need to be considered. Strattera is adrenergic, and so it can speed up heart rate and blood pressure increases, and then atomoxetine has some bladder, Ditropan, oxybutynin has some bladder issues as well. So it'll need to be looked at carefully. It's currently in peer review, so we'll see what that shows. But they're now at the FDA, Food and Drug Administration, for review, and so drug treatment for sleep apnea may be on its way using this approach. So now I'd like to talk about weight loss. I'm a big proponent of weight loss. What I often say is if diet and exercise were highly effective, I would be skinnier. And so we're left with pharmacotherapy as well, although not to dismiss diet and exercise, which are still important. So we published this study in a meta-analysis just prior to the release of the SURMOUNT-OSA results. On the x-axis here is change in body mass index, and the y-axis here is the change in the apnea-hypopnea index. So as patients lose weight along this red line, they have less and less sleep apnea. The blue dots are lifestyle studies, diet and exercise. People lose a little bit of weight, their sleep apnea improves a little bit. The black dots are surgical studies where people lose a lot of weight, their sleep apnea improves a lot. And the green dots were drug studies that were available at the time prior to the release of the SURMOUNT-OSA result. There's a lot of debate about the shape of this curve. Is it linear? Is it curvilinear? Is it a threshold? You get below a certain weight and your sleep apnea resolves. Interesting thing for me is the amount of scatter. You can have huge weight loss and have modest improvements in sleep apnea, or in some cases, minimal weight loss and major improvements in sleep apnea. So there's a fair amount of scatter here. The SURMOUNT-OSA result I'll show you was about 20% loss of body weight and about 60% improvement in the apnea-hypopnea index, so suggesting the improvement in sleep apnea severity can be attributed to weight loss. We'll talk more about that. Okay. So there's a drug called tirzepatide that you would have heard of from watching TV or from talking to your patients. Tirzepatide is also known as Mounjaro or Zepbound. Tirzepatide is a GLP-1 with GIP. What does that mean? It's a glucagon-like peptide 1 with GIP is gastric inhibitory peptide, also known as glucose-dependent insulinotropic polypeptide, which is a mouthful, pun intended. So this is different from semaglutide. Semaglutide is also known as Ozempic or Rybelsus or Wegovy. If you go head-to-head with tirzepatide and semaglutide, tirzepatide has about 20.5% weight loss and semaglutide about 13%. So it is a more potent medication, works through different mechanisms. So tirzepatide is the one we studied here in the so-called SURMOUNT OSA result. The design of the study, there was 2 different studies. Study 1 were non-CPAP patients who couldn't or wouldn't use CPAP, and they got either tirzepatide or placebo. Study 2 were CPAP patients who got either tirzepatide or placebo. There's no direct comparison of tirzepatide and CPAP, and so it's tempting to try and draw conclusions, but that wasn't available. We could compare tirzepatide to placebo to say it's better or worse. We can't say it's better or worse than CPAP. So study 1 were non-CPAP patients, study 2 were CPAP patients. All patients in both arms got monthly visits with registered dietitians. And so you'll see improvements in the placebo group, probably not from placebo effect, but from very good standard of care. In the CPAP group, we withdrew the CPAP for 1 week prior to each sleep test to see if the drug was doing anything as opposed to seeing if the CPAP was working. So we looked at age over 18 years. There were no children in the study. Looked at moderate to severe sleep apnea. There's no mild sleep apnea or snoring. BMI over 30, so nobody was lean or overweight. We excluded people with diabetes. That's important because people with diabetes tend to lose less weight with GLP-1 receptor agonists than people without diabetes for reasons that aren't entirely clear. So the primary objective here is to demonstrate that tirzepatide at a maximum tolerated dose of 10 or 15 milligrams subcutaneously once weekly is superior to placebo for change in the apnea-hypopnea index from baseline to week 52. In isolation, the apnea-hypopnea index is just a number, and just trying to improve that number is not very exciting. So we looked at concomitant secondary outcomes as well. So the key secondary outcomes I'll show you here. By way of emphasis, all of them were controlled for multiple comparisons, and all of them were pre-specified. So there was no data dredging or fishing trip or funny business here. These are all pre-specified, controlled for multiple comparisons. The idea is here to look at tirzepatide versus placebo for the percent change in the apnea-hypopnea index, the change in the sleep apnea-specific hypoxic burden, the area under the hypoxia curve, systolic blood pressure, high sensitivity C-reactive protein, which we know are strong cardiovascular risk markers, and we looked at symptoms based on the PROMIS scores. U.S. National Institutes of Health have developed these PROMIS scores, patient-reported outcome scores. You have to be careful because if somebody's losing 20% of their body weight, it's impossible to effectively blind any of these studies, and so subjective things become a bit bogus. With concomitant improvements in objective and subjective, I take them much more seriously, but in isolation, patient-reported outcomes in unblinded studies are kind of silly. So study 1 are the non-CPAP patients on the left, study 2 are the CPAP patients on the right. We studied a total of about 500 patients in total. It was a fairly well-done study. Some of the placebos dropped out because giving yourself a weekly injection probably isn't a lot of fun. But among the tirzepatide patients, the majority completed the study, both in study 1 and in study 2. These were typical patients that we see in clinic, average age about 48, about 30% female. Now that's important. Some sleep apnea studies are predominantly men. Some bariatric studies are predominantly women because that's who shows up in bariatric clinics. Women tend to lose more weight with GLP-1 receptor agonists than do men for reasons that aren't entirely clear. And so we mandated at least 30% women. We had pretty good diversity, about 30 or 40% Hispanic. The percent of African Americans is lower than you might like, around 5%. This study was done in 9 different countries. Within the United States, we did pretty well in terms of diversity with African Americans. But in Europe and in Asia, there are very few African Americans. And so across the board, 5% is lower than we'd like for as a percentage. But within the United States, we did pretty well in terms of representing the population. They had class 2 obesity based on BMI about 39 at baseline. We excluded diabetes, but many of them had pre-diabetes and hypertension. They had fairly severe sleep apnea and apnea-hypopnea index of 51 events per hour, or 50 events per hour at baseline, which is severe sleep apnea. We excluded mild apnea, so they're all either moderate or severe. And based on the symptoms here, the scores were relatively modest. These patients came from primarily endocrine and bariatric clinics rather than sleep clinics where they maybe were perhaps more symptomatic within sleep clinics. So this was published in New England Journal of Medicine back in 2024. Tirzepatide for the treatment of obstructive sleep apnea and obesity. On the basis of this study, we got FDA approval on December 20th of 2024 for moderate to severe sleep apnea in people with obesity. I'll point out this is a $100 million study. Tirzepatide will probably be the first $100 billion drug, and Eli Lilly just had a market cap of $1 trillion, just to give you a sense of the scale of what we're talking about here. On a personal note, when this paper was coming out, I told my daughter, I have a paper coming out in the New England Journal of Medicine. She said, "Oh, how many times have you been there, Daddy?" I said, "I don't know, I'll check." So I looked it up and I said, "Well, it's 13, but some of them are reviews and editorials that don't really count." And she said, "13, but Daddy, it comes out every week." Can't please everybody. So in terms of the primary outcome, we looked at the apnea-hypopnea index. I'll show you two sets of analyses. There's an efficacy analysis, who stayed on drug, and a modified intention to treat based on randomization. The two sets of results are almost identical. I'll show you both for transparency. Study 1, the non-CPAP patients, you see a marked improvement in the apnea-hypopnea index, both clinically and statistically significant, about 25 to 30 events per hour, 30 events per hour in study 2, which is nothing to sneeze at. But let's look with concomitant changes in secondary outcomes, which is why we did the study. So lots of different results here. I made it small just so I can go through them. Percent change in the apnea-hypopnea index in study 1 and study 2 is around 55%. If you look at high sensitivity C-reactive protein, a strong marker of cardiovascular risk, both in study 1 and study 2, there are marked improvements with tirzepatide versus placebo. The percent of patients getting into remission with either an apnea-hypopnea index below 5 or mild apnea without symptoms, we're talking about 40 or 50% of patients with tirzepatide versus placebo, both in modified intention to treat and in the efficacy analyses. If you look at the sleep apnea-specific hypoxic burden, there are marked improvements with tirzepatide versus placebo. Some improvements in placebo, probably again from diet and exercise, monthly visits with registered dietitians in the control group, as well as the treatment group. Body weight came down about 20%. To put that in context, if I weighed 200 pounds at baseline, 20% is 40 pounds. So it would take me from 200 pounds to 160 pounds, quite a game changer for these people. And then the result that probably surprised me the most, systolic blood pressure came down 9.5 millimeters of mercury, quite a whopping improvement in systolic blood pressure with tirzepatide versus placebo, both in study 1 and in study 2. So let's look at these patient-reported outcomes as well. Again, as a point of emphasis, when somebody's losing 20% of their body weight, it's hard to blind anything. And so symptoms in isolation become meaningless. But with concomitant improvements in subjective and objective, I take them more seriously. So we look at patient-reported outcomes, the PROMIS scales developed by the U.S. National Institutes of Health, the sleep-related impairment, which is daytime symptoms, and sleep disturbance score, which are nighttime symptoms. Both of them improve markedly with tirzepatide versus placebo. Some improvements with placebo, often, again, probably misreporting or incomplete blinding, but significant improvements with tirzepatide versus placebo in both daytime and nighttime symptoms. So let's talk about safety. When you follow patients carefully, relatively unfit patients, they will have side effects. And so both with placebo and with tirzepatide, about 75 to 80% of patients have some sort of treatment emergent adverse events. That's par for the course for dealing with patients who are unwell. Serious adverse events were numerically more with tirzepatide than placebo in study 1, although some numbers were small. Numerically more with placebo than with tirzepatide in study 2, but again, numbers were small. Look at GI side effects. About 25% of patients get nausea, vomiting, diarrhea, constipation, both in study 1 and in study 2. The good news is twofold. Number one, there's very few patients dropped out of the tirzepatide because of GI side effects. As I showed you, the majority of patients completed enrollment up to week 52. So the GI side effects were not prohibitive in terms of continuing the study. And by the end of 1 year, these GI side effects have largely gone away. But it is an important thing to tell patients that about 25% will get GI side effects, and just to be aware of that. Adverse events of special interest. We're worried about pancreatic cancer, we saw 0. We're worried about medullary thyroid cancer, we saw 0. We're worried about death, we saw 0. We did see 2 cases of pancreatitis, both with tirzepatide, 0 with placebo. So some of you know I do critical care as well, so I know a modest amount about pancreatitis. So I put on my critical care hat and did a deep dive in those 2 patients. They're both quite mild, and both were self-limited. I couldn't figure out why they were diagnosed, and so I was going through the charts and looking at it carefully. I believe what happens is what's called an ascertainment bias. People come in with nausea, vomiting, abdominal pain. People check an amylase and lipase just because that's the company it keeps. And so I believe these 2 might have been diagnosed just because of that ascertainment bias rather than a severe complication of the drug. These 2 cases are not to be ignored, certainly. We saw 0 with placebo and 2 with tirzepatide, but it's not something I was particularly worried about after I did that deep dive. So the takeaways from Surmount OSA: tirzepatide, the maximum tolerated dose, demonstrates superior and clinically meaningful improvements in obstructive sleep apnea-related sleep disorder breathing. Tirzepatide, the maximum tolerated dose, demonstrates superior improvement at patient-reported quality of sleep and sleep-related functioning. Treatment with tirzepatide maximum tolerated dose translated to clinically meaningful improvements in obstructive sleep apnea and obesity-related cardiovascular risk factors. The safety and tolerability profile of tirzepatide in people with moderate to severe sleep apnea and obesity was generally consistent with the safety profile of tirzepatide and other incretin-based therapies in people with obesity. We did some mediation analyses as well. People want to know what's an obesity effect versus what's a sleep apnea effect versus what's a direct effect of the drug. And we just published that in January in Nature Medicine. So in Nature Medicine, we had this paper, tirzepatide and obstructive sleep apnea cardiometabolic risk. Suffice it to say it's complex. Some things are more obesity related, including the blood pressure improvements largely attributable to improvements in body weight. For other things like glucose and lipids, it's attributable partially to sleep apnea and partially to body weight. For some things, there's direct effects of GLP-1s in the carotid body that may affect sympathoexcitation and whatnot. So they're direct effects of the drug that are interesting as well. So it varies by outcome. What's in the future of GLP-1 receptor agonists? There's a joke here. We say we can't tell the future, but sometimes we can make the future. So that's the joke. There's a drug called orforglipron, which is now called Foundayo, got FDA approved on April 1st of 2026. We're doing a large study on that in sleep apnea called Attain OSA. I'm the global PI for that study, which should read out in August, and the plan is to present that at the American Heart Association in November of 2026. Orforglipron got FDA approved recently as an oral GLP-1 thing that's a non-peptide that gets absorbed. There's other studies on what's called bimagrumab. Bimagrumab is an activin inhibitor, so it helps to prevent the breakdown of skeletal muscle. When people lose a lot of weight, they lose skeletal muscle as well. So bimagrumab is a way to prevent that, and if you combine that with the GLP-1, you get almost all the weight loss is fat rather than muscle. So that's the BELIEVE study, just published in Nature Medicine last month. Eloralintide is an amylin-based drug. It's not a GLP-1. Relatively fewer GI side effects, since that may be well tolerated in people that can't tolerate GLP-1s. There's a drug called retatrutide. It's a triple G. What does that mean? GLP-1 with GIP with a glucagon agonist. And that drug combination appears to have even more weight loss than tirzepatide. And we should have a readout in the so-called TRIUMPH studies in the next week or two, which again, we're studying for sleep apnea as an indication, including enrolled in patients in obesity and diabetes studies as well. So in terms of FDA approvals, we have it for orforglipron now. We'll see if we get it for some of these other agents there, but there's a lot of excitement here. There's also a drug called WVE-007, which is an siRNA. You inject it once and it reprograms your nucleic acids to prevent breakdown of actin and myosin. It's an siRNA that works through RNA interference. And we'll see where that goes, but it looks quite exciting as a way to preserve skeletal muscle as well. So my final slide here, conclusion. It's an exciting time for the obstructive sleep apnea field. When I started in this area in 1998, we had CPAP and nothing else, and I've had to come up with a new treatment. It took 26 years, but eventually we got there. Pharmacotherapy is now here. It's not just coming. There are a number of new FDA-approved therapies, which I've highlighted today. Individualizing therapy may be viable, as Jag had mentioned. It's certainly an exciting time for ongoing research. So I'll stop there. I'd like to thank you all for your attention. It's been my honor to be here. I'd be happy to take any questions if there are any.
Thanks so much. As an obesity person, I love the review of ongoing research in the area. I want to have you go back, if you will. You talked about your background in physiology. What do you think is going on in the younger people who develop it, or thin? You said, full of young, thin women. What's causing their sleep apnea, and how are we going to, you're not going to put them on tirzepatide. How are we going to approach treatment in those people?
Yeah, it's interesting. I just wrote an editorial on that, is lean sleep apnea a different disease? And yeah, tirzepatide may not be the solution, although it might help a little bit, I don't know. There are anatomical factors like craniofacial structure and soft tissues. Particularly, we know in African Americans, even without obesity, the soft tissue structure and things. Same in some Asian countries, in Japan and China. Even with much less obesity, they have sleep apnea risk from craniofacial structure, those sort of things. There's the upper airway dilator muscles. So if those are dysfunctional, exercising those muscles or stimulating them pharmacologically or electrically may be a viable approach. There's control of breathing issues that are a bit more complicated, but there's also pharmacological targets there, which again I'll talk about if you invite me back for pulmonary gangrenos, and then other targets like that. So yeah, there are multiple underlying mechanisms. Obesity is one of many. Yeah. And bear in mind that many people with obesity don't have sleep apnea, so there's complex interactions of all these different pathophysiological variables. Yeah.
Thank you so much for the lecture. I have a quick question. Now that insurers are preferring Wegovy over, sorry to use brand names, but Wegovy over Zepbound because of discounting that the manufacturers are doing. And we don't have direct OSA data for Wegovy or Ozempic. And at least the head-to-head trial has about a 5% difference in weight loss. How much do you think that last 5% is giving us the bang for the buck in sleep apnea?
Yes, it's a good question, and I'll answer that several different ways. So semaglutide is also known as Wegovy or Rybelsus or Ozempic. Tirzepatide is also known as Zepbound or Mounjaro. There are different drugs, and yeah, the SURMOUNT-5 was in New England Journal last year. Head-to-head comparison is 20.5% versus 13%. So there's a 7% difference maybe in body weight. But there's off-target effects of GIP and stuff that we don't know. And so in my view, if you believe in evidence-based medicine, whatever, tirzepatide is the way to go. Now, obviously, I have a bias because I'm involved with the tirzepatide studies. CVS Pharmacy signed a deal with Novo Nordisk to preferentially give semaglutide. On social media, I listened to some of those podcasts and stuff. They were saying go out and get a sleep study. If you go out and get a sleep study, you get a sleep apnea diagnosis, then you can stay on tirzepatide. And so it drove a lot of business their way. And I don't know how much of the $100 billion is from that type of thing. So in my view, yeah, weight loss is weight loss, and it's good for the body in terms of cardiometabolic risk, but there's really no data that semaglutide improves obstructive sleep apnea. So my preference is tirzepatide based on the evidence and based on the marked degree of weight loss. In terms of how much weight you need to lose, I showed you that graph at the beginning here with that. So if percent change of body weight with semaglutide is up here somewhere, it's considerably less than here, but it's not zero. So, but that's just a prediction. You have to do a randomized study with semaglutide to really draw conclusions. We're doing that now with orforglipron because the orforglipron has less weight loss than tirzepatide, the oral GLP-1. So that may also have comparable weight loss to semaglutide. We'll have to see. There was a study called Achieve-3, which was just in the Lancet comparing oral orforglipron with oral semaglutide, and orforglipron was better in terms of glycemic control and whatnot in people with diabetes.
You said that patients with increased daytime somnolence have the highest cardiovascular risks. Have there been studies or trials looking at that population, looking at cardiovascular outcomes, because that seems to be the most, right?
The sleepiest ones?
Yeah. Define not AHI outcomes, but actually cardiovascular outcomes.
Yeah, it's a good question. It's actually an ethical discussion that comes up about that. So what happens in these randomized studies is who wants to be in the control arm of a randomized controlled trial waiting for a stroke and a heart attack to occur? What I often say is I wouldn't put my mom in the control arm of a randomized controlled study waiting years for a heart attack to happen when we know their effective treatments. I would certainly put my mother-in-law in that study, so kidding. I'm kidding. So it's very hard to know what. Kidding. A lot of lawyers in New Jersey, right? It's hard to know who to put in those randomized controlled studies. If you take the most severely symptomatic patients and do randomized controlled trials on them, then you have severe, untreated, sleepy patients who are at risk of motor vehicle accidents and these kinds of things for a long time. So how to handle that isn't clear. You could do comparative effectiveness, or you compare two active treatments, or you could treat the sleepiness symptomatically with modafinil or Provigil or something just to put a Band-Aid on the problem, or you could do non-randomized studies like the ones shown here in the meta-analysis. There's not a right answer. The patients you'd want in a randomized trial to show improvements in cardiovascular events are ethically the hardest ones to withhold therapy from, and that makes it tricky.
Comparing the different drug classes and the amount of weight loss, do you think it's more important for the absolute weight loss decrease or potentially where you're losing the fat, for example, let's say in the tub?
Yeah, the short answer is I don't know, but it's an important question. It says colleague Richard Schwab is a co-author in Surmount OSA who does a lot of imaging work. And he's a co-author in Surmount OSA because we did some imaging in Surmount OSA. We haven't published that yet. It looks to be underpowered. We only got MRI imaging in a subset of patients. There are some changes in tongue fat that occur with tirzepatide, but minor and maybe not statistically significant. I'm not sure yet. We're analyzing that now. So I suspect you're right that it depends on how much weight loss and where the weight loss is occurring. So for example, abdominal fat is more common in men, and that may be more important for upper airway patency than pelvic fat and things that are more common in women. So that's speculation right now, but there's some suggestive evidence that the distribution of body fat, in addition to the absolute fat, are both important.
So Atul, I have a question related to REM-OSA, because if you look at the pathophysiological data that we have in endotypes, it always looks at non-REM OSA, all of those features. REM-OSA seems like upper airway muscle being the primary target, probably. Do we have data on the newer drugs, the 8109 combination on REM-OSA and what happens there?
Yeah, so 8109 is this drug combination of atomoxetine, oxybutynin, which is with the enantiomer. That's in that context, what they presented at Chicago, which again, it's not published yet, so it's not peer reviewed, but there was REM suppression, there's just less REM sleep. And so the REM AHI was changing proportionally, but some of that was just suppression of REM sleep. We have a presentation on Surmount OSA with tirzepatide at the American Thoracic Society meeting next week. Scotty Sands, who you know, is going to present that. We do see improvements in the REM AHI with tirzepatide, but sort of with concomitant improvements across the board. So improves in non-REM and in REM. That's a bit nuanced for a general medical audience, but we can talk more offline. Yeah.
Any other questions?
Yeah, back there. Back there, yeah, back row.
So in using this in clinical practice, we start someone on Mounjaro, they've been on the CPAP machine. At what point do you feel comfortable eliminating the CPAP machine, or do we keep continuing the CPAP machine?
Sorry, I had a slide on frequently asked questions, and that frequently asked question, that slide is missing. So we did publish a paper, a follow-up to the Surmount OSA in study 1, the non-CPAP patients, to look at the time course of changes. And we did do periodic assessments in the non-CPAP patients at 4 weeks, 12 weeks, 16 weeks, and then at the end. By 4 weeks, you start to see improvements of the apnea-hypopnea index on the order of 6 events per hour. By 12 weeks, there's further separation. By 20 weeks, there's statistical significance. There are parallel changes in body weight that occur as well. So when I get that question saying, when can I withdraw the CPAP, the answer is I don't know. But as the weight improves, the apnea-hypopnea index is improving. And so you can reassess clinically at some point. If you think they no longer need this, then it'd be worthwhile doing a reassessment and taking a look. Now the problem is, or the good part, I guess, is some patients vote with their feet. So we often see that after bariatric surgery, right? Patients will stop their insulin, they'll stop their CPAP, they'll stop everything and think it solved all their problems. And there are some abrupt improvements you see after bariatric surgery, which I don't fully understand. Maybe Gene can help us understand. But patients often vote with their feet, saying, I stopped using my CPAP because I didn't need it anymore. But it is important to do serial follow-up on those patients because some patients will regain weight. There's others, even there's 7-year follow-up from Gura Pilar in Haifa, Israel, 7-year follow-up after bariatric surgery. Even those who don't regain weight, some will redistribute body fat and they'll develop sleep apnea again. So it's not good to use the word cured because if patients stop the drug, the weight will come back. And even if they maintain the weight loss, there's some risk that sleep apnea could reemerge.
All right.
Are
Thank you very
there
much.
questions online? Or?
Oh, yeah. Everything you said? No, no question.
Thank you very much.
Give you the clock.
Thank you so much for your lecture. Want to get a picture? Oh, sorry, I didn't see it. Very nice. Thank you. Yeah, I was trying to get out, I mean, it sounds like a lot of it is mechanical, right? I mean, it's muscular, structural.
Is that, yeah, you got a picture?
I got a picture.
Okay, thank you.
Yeah, so the control of breathing, so, I mean,